The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. My name is Corey Thornton. I am the GM with the Open Minds Market Intelligence team, and I would like to welcome you to today's Circle Elite Executive Roundtable, Measurement-Based Care, the Aurora Mental Health Center Case Study. Today's roundtable features a few members of the Aurora team: Kathy Snell, Chief Strategy and Operations Officer; Kirsten Anderson, Chief Clinical Officer; and Amber Olson, Clinical Director. They are joined today by Dr. Jason Washburn, Chief Clinical Officer at OWL, and Chief Psychologist at the Northwestern University Feinberg School of Medicine. Before I turn it over, we have a few housekeeping reminders. Your audio will be muted during today's briefing. We encourage you to submit any questions you may have using the chat box located on the right side of your screen. We will present audience questions at the end of the presentation. And finally, the slides and recording for today's briefing will be available on the Open Minds website tomorrow. And with that, here's Dr. Washburn to get us started.
Great, thanks so much, Corey, and thanks everyone for joining us today. Really excited to be here with, in particular, with my partners at Aurora Mental Health and Recovery to talk about how measurement-based care can be utilized to really enhance the functioning of organizations and ultimately positively impact patient care. So let's go ahead and get into that. We're going to walk through a bunch of different things today. The first thing we're going to do is talk about why measurement-based care is important in behavioral health. We're then going to have Aurora talk about what they've done as it relates to measurement-based care and how they identified the need for it and how they chose a solution to implement and what the results of that have been. And then we'll end up by talking a little bit about the outcomes. What have we seen in terms of the impact that measurement-based care can have on an organization? So let's jump into it. Again, as Corey said, please feel free to put questions into the chat. Don't hesitate to put in comments or ask questions, and we'll try to have some time at the end to answer as many as we can. So what we want to talk about first is the importance of measurement-based care and how that is critical in so many different ways. So OWL is a digital platform that provides measurement-based care both to providers as well as for health plans, with the ultimate goal of improving the care for members of health plans and for patients of providers. One of the things that I think is really useful about measurement-based care is it ties all of those constituent groups together. It really helps to address common pain points across all of these important constituents. And for that reason, measurement-based care is often seen as something that's of utility for everybody, and ultimately helps to get better and faster care to our patients, helps to address pain points such as access to care, helps us to understand better how to monitor change over time, respond to change over time, and to ultimately be the most effective we can be as providers. So with that, let's jump into what actually is measurement-based care. So when we talk about measurement-based care, most of the time these days, people know what we're talking about. But just to level set, let's pull up a definition that's been around for a couple years now. Lewis defined measurement-based care as the systematic evaluation of patient symptoms before and during each clinical encounter to inform behavioral health treatment. And as you can see with our little schematic down there, we look at measurement-based care at the time that patients come in to start a treatment with us. We also then do that as they are continuing to come back for care. The patient will complete the measurement. The measurement then will provide the results. And then there's a collaborative review between the patient and the provider about those results. What's also really useful about measurement-based care is it can level up rather than just being stuck at the patient to provider perspective, which, you know, if you're doing measurement-based care right now, in particular on paper and pencil, oftentimes that's where it stops. When you utilize a technological solution like OWL, you can also then aggregate those results and you can start to answer population level questions that are otherwise really hard or if not impossible to answer without it. So when we look at measurement-based care, I'm sorry, hit the wrong button. There we go. When we look at measurement-based care, sometimes I get the question, well, why do we need this? I already know the work that I do is effective. Why do I need to measure it? Well, we know from the literature, several different studies now showing the effectiveness of measurement-based care when it's implemented correctly. When we see measurement-based care done in a comprehensive way within an organization, we see a significant response to treatment, a significant improvement in the response to treatment, as you're seeing from this bar graph. And this was in a very controlled study showing an increase of over 20% in terms of response to treatment, and the number of patients actually reaching remission is even more significant, from about 30% to about 75%. So a really significant impact on treatment effectiveness. And so we see that for a couple different reasons. Number one is we see that when people are using measurement-based care, they actually need less sessions. They're more efficient, right? They're not only more effective, they are getting people better quicker. So we see a 50% reduction in the time to response and time to remission. And what we're seeing there is that clinicians, when they have the tools that they need to understand where their patients are at, to understand which symptoms are getting better and which symptoms are not, to understand where is their functionality, they can then target that more specifically and more efficiently, resulting in better outcomes. And so when we look at measurement-based care, it helps us to be precise. And we know that without this, when we are not measuring something, we are not precise. Now, again, I have colleagues of mine who say, I'm very precise. My judgments are really quite good. I know how well a patient is doing. I ask the patient how they're doing. I myself have relied on this in the past. A good example is a couple months ago, I asked a patient, so how's it been the last week? And they said, great, things are a lot better. And then I looked at their scores, and they were no better. They were exactly the same. They hadn't shown any change. And so sometimes when we rely on the subjective input of our patients, or when we rely on our own abilities to understand where somebody is at, we're not going to be as accurate. We know from the literature that clinicians struggle to detect when a patient is doing worse, when they're starting to deteriorate. And in general, myself, tend to overestimate how well our patients are responding to our treatments. When we have actual data, we can then be more precise. And so I often talk about this as the measurement-based care as the blood pressure cuff of behavioral health. You wouldn't expect to go to your primary care physician and them not to assess anything. You would expect them to assess something. You would expect them to look at your heart rate, look at your blood pressure, weigh you, do other blood tests and things like that. Why? Because it provides a precise metric of what is actually going on. And so we need that precise metric in behavioral health just as much as we need it in medical or surgical context. So when we're looking at measurement-based care, we have to use it routinely. I've worked with some organizations who say, oh, yeah, we do that. We do outcomes. We assess at the time of admission. We do a screening. And then sometimes at discharge, we'll do a screening too to see where they're at and see what the change has been. And that's good, right? We want to assess people at admission. We also want to know change over time. But measurement-based care is most effective when we are using it like the blood pressure cuff, when we are assessing it routinely, when we are looking at symptoms, looking at functioning, looking at quality of life in a routine way, a frequent assessment that is going to coincide with the treatment session, that's going to allow for that collaborative engagement with the patient to really understand what's going on and to modify the treatment when necessary. So hopefully at this point, in the few minutes that I've been presenting, I've convinced you on the importance of measurement-based care. And most people agree, measurement-based care is important. We asked a whole bunch of folks in a community mental health national organization about, is this useful? Is this important? 83% of respondents said, oh yeah, we like measurement-based care. And then we said, okay, how many of you are using it? 16%. So why are we not doing this, right? We're not doing this because it's hard. It's hard. It takes time. It takes effort from the clinician. A lot of times, again, people are collecting this on paper and pencil. They're looking at, they're maybe having to score it right then and there. They're also not aggregating it, so it doesn't help them to understand how they're doing with their entire patient population. So what we need is for measurement-based care to not be a burden. We need it to be something that's easy. And this is where technology comes into play. Technology makes measurement-based care feasible. It allows us to engage patients in their treatment through their measurement-based care processes. It helps us to guide that care and to engage the patient in a collaborative discussion of the results rather than the process of getting the data. And ultimately, when we are using technology, we can then aggregate it and look at those higher level questions, right? What patient populations are we the most effective with? Where are some specific demographics that we are not as effective? What are some other factors that we might want to look at, such as social determinants of health, and how is that influencing the effectiveness of our programming? So technology really allows us to go above and beyond to make measurement-based care not only easy and feasible, but also to maximize its greatest advantages. And we see that with our own data within OWL. So we see within OWL a replication of what we are seeing in the well-controlled academic literature. We're seeing a 56% reduction in time to remission when people are frequently using the OWL. We see a very high engagement rate, almost 90% of the time when we will provide a measure to a patient to complete, they will complete it. We also see a reduction in no-show rates because of that level of engagement. So about a 26% reduction in engagement rates. And we also are seeing opportunities, right? Opportunities when we aggregate the data. For example, we all know of the problem of patients, particularly from a psychotherapeutic perspective, but also from a medication perspective, where they're being seen over time when they're quite stable. We also can identify that with outcomes. We can tell you which are the patients that are in a remission period where they have had a stable symptom presentation that's below clinical threshold for 4 months or more. And we have shown that in sample across sample with an OWL, approximately 30% of the patients are in that stability range. 30%, that's a lot of patients. If we can move those patients into a lower level of care, if we can move those patients to be seen by their primary care physicians, or to be seen every other week, or perhaps in a check-in model, then we can open up access. And we know, since the pandemic, things have not gotten better in terms of access. We need to be able to provide the highest level of care to the patients that need it, and then to move those patients out as quick as possible and open up for those patients that really do need that high level of care. All right, so with all of that, I hope I have laid a good foundation for why measurement-based care is important, what it can do for us, and what we are seeing in OWL in terms of some of the benefits of it. But I don't want you to take it from me. I'm the Chief Clinical Officer of OWL, so obviously I'm a champion. I'm very excited about OWL. But let's see how it actually plays out in the real world with Aurora Mental Health and Recovery providing their insights.
Thanks, Jason. Appreciate it. Just a bit about Aurora Mental Health and Recovery so you can sort of get a sense of who we are and compare the kind of organization that you run or are a part of. So we serve a community of about 400,000. We have about 600 staff, and we have programs that serve from infant mental health through older adult across the continuum, as many of you probably do as well, from prevention and health promotion services through early intervention, community-based services. So we provide services in our buildings very much in the community, in schools and in other community locations, and then intensive and acute services as well. So we have, if you could move to the next slide, please. Thank you. So I've been doing this work in community mental health in Colorado for several decades, and I can tell you that entire time, this has been an issue that we've struggled with. We've always known we want to be able to demonstrate how our clients are doing in care. We have good anecdotal evidence of client improvement. We have never had a good, solid, sustainable way of being able to measure across the board what we think we see in our client population. So we've tried a lot of different things. I won't go through all of these, but we have tried. We have a state association. We've probably had 3 or 4 different work groups over the years to say, how do we tackle this issue together? How do we really demonstrate the value of what we do? And so that's really where we started with OWL. It was really, how do we look at how our clients are doing? And then on the other hand, we've also implemented a couple of different methods to try to get toward measurement-based care, but we weren't getting all of the way there with any of these methods. We had problems with being able to track, paper and pencil, lots of things stacked on desks, lots of file cabinets with lots of data in them, but getting all of that data to come together in a usable way was really challenging. Another thing that we found challenging over the years was being able to ensure that our clinicians and our clients have access to these measures on a regular basis and are using them on a regular basis. And without some technology to kind of pull all of that together, it was really difficult to get there. Also, a lot of the measures that we had tried to use over the years had long intervals between administration. As Jason was mentioning, you might do it at the beginning, you might do it every 6 months or at discharge, but you lose a lot of clients there, right? Because they may discharge in and not complete final measures. So we may never know what their outcomes were. And then we also do have measures integrated in our EHRs, as I'm sure many of you do. Some of the same challenges, the data is there, but aggregating that data and ensuring that those measures are actually completed across our client population has just been a challenge for us over time. So next slide, please. So we were fortunate to receive funding through SAMHSA as a CCVHC expansion site about 2.5 years ago. And we focused on a number of different criteria, but these 2 criteria, or this criteria specifically, really spoke to data collection, reporting, and tracking. And we saw this as a real opportunity for us to look at what's out there that might be able to bring together both that idea of quality clinical care and the idea of outcomes, being able to demonstrate value, not only as a way to help our clinical teams stay focused on outcomes, help us to be able to describe our outcomes to our payers, but also to move towards value-based care. And pulling those 2 pieces together, I think, is really important and critical in that pursuit. And we are finding that there's a lot of interest within our community, with our payers, with our state officials about the data that you'll see a little bit later. So we're seeing some really positive outcomes, not only within our center, but within the environment, the greater environment. So Kirsten.
Thanks, Kathy. So there are a variety of options to consider in choosing the best solution. And so I wanted to talk through some of the things that we were looking for in the most ideal partner to improve our measurement-based care at Aurora Mental Health and Recovery. As Kathy mentioned, we have a wide range of programs here. We have about 25 different clinical teams and do everything from outpatient to, we have a team that works with unhoused individuals and does street outreach. And we have teams that work with refugees and immigrants and use health navigators to be able to speak to those clients. So we needed some sort of tool that could really work with all of these different types of clients. We cannot just do the PHQ-9 with everyone, and that covers our population. So we wanted to cover all ages, all sorts of conditions, a tool that could be implemented in a variety of different manners with people depending on what they needed. And we wanted to be able to be sure, as Jason mentioned, that we were able to measure people at routine intervals to really collect sufficient data to be engaging in measurement-based care in the best way possible. We also needed it to integrate into our EHR, so we did not continue to want to use paper that goes into file cabinets, but we wanted to find some sort of tool where the technology helped to facilitate the utility of the tool. And we wanted something that had all of these different measures so that our clinical managers and subject matter experts could pick the measures and the bundles that worked best for their teams and folks. The other thing that was really important to us is that it was a tool that our clients and our clinicians would actually be able to utilize. We engage in the one more thing type of approach sometimes here, where we're asking clinicians to do one more thing a lot, and we wanted this to really be effective to them and something that we could really champion as actually helping clients. So we wanted the broad level data that we could use center-wide, and we also wanted them to be able to use it with their clients and engage in measurement-based care and all of its benefits and perks. So drum roll, we chose OWL, of course, which is why we're here today. OWL has over 300 clinically validated measures in their library, so it really did allow us to pick different measures for different teams. They have a very high patient engagement rate, which I think speaks to the fact that clients are willing and able to do it and buy into the purpose of it. And it was a tool that clinicians also bought into. So for all of our different needs, OWL was the best choice for us. The other decision that we made that was very important is that we chose Dr. Amber Olson to implement this at our center. So Amber is one of our clinical directors. She oversees a portion of our programs, but also is a psychologist, and so was able to use her knowledge of data and research and assessment to help our managers pick the best tools. So I will toss it over to Amber to talk through how she led the implementation of this throughout our Mental Health and Recovery Center.
Thank you, Kirsten. So I'm going to share a little bit about our process just to help you all better understand sort of what it takes, right, to pull this off. Because we are a large, diverse organization, we knew that in order for us to have success with our implementation and also to ensure as much as we can staff buy-in, we thought a pilot would be a good way to start our process. So I specifically chose teams with strong, enthusiastic leaders, teams that at the time, this was 2020, so a difficult time, but teams that had more stability, not a ton of issues with retention, and also some clinicians on the team who either have had some previous experience doing measurement-based care or just training in graduate school around it, just knowing that we could get them to help champion the project. So for us, that was one of our adult outpatient teams, and then also one of our access teams, kind of one of our front doors of the center. We piloted OWL manually first, so we did not integrate our EHR at this point. And it just allowed us a chance to really look closely at the workflows, consider any potential hiccups or workflow issues, work to resolve those early on, consider some things maybe we hadn't considered to kind of prevent us from having that down the road in our big rollout. It also helped us gain some early buy-in from those two teams and leaders so we could get some early champions in the project. We didn't, thankfully, experience any significant issues with our pilot. Feedback was overwhelmingly positive for the teams. So we moved to our second phase with integration. This comprised a heavy part of the work for us. It included a small work group of folks, including myself, sort of from the clinical perspective, and a small group of folks from IT. So we had a full stack developer, a senior enterprise application specialist who really knows our EHR incredibly well, and an IT project manager. So we met a lot, multiple times a week for a long period of time. The first part of that work was really creating different use cases. So trying to be really thoughtful thoughtful and planful around what are all the various types of scenarios we're going to be facing throughout all of our different clinical teams. This team has this workflow, this team has that workflow. What if a client's in both teams? Who can get the measure? So lots of things for us to consider and work through. And while that was going on and our full stack developer was starting to work on the actual integration, I was then meeting individually with our various clinical directors and managers, working out and better understanding the unique intricacies of all the teams within the divisions, their workflows, more about the community they serve, as well as trying to explore what are the things you want to, what are the outcomes you want for your team, what is important to measure for your team, and the needs of your community. Well, I took a team by team approach again that felt the best for our center. A cookie cutter process, as Kirsten mentioned, isn't going to work for us given the diversity of their teams and the communities that we're serving. I thought of my role in some ways as a consultant to the team. So when I was meeting frequently with the different directors and managers, I was teaching them and kind of championing OWL, explaining how it works, why it's going to work well for us, allowing, trying to answer any questions they have, and then challenges that they may foresee with the workflow or challenges they may foresee with collecting measures based on the communities they're serving, so we could get ahead of those, and then assisting them in putting together what we call measure bundles. So that's a grouping of measures that are automated that people receive at different points in their treatment. So we really felt like customizing it by team, although that takes a lot of work, would really help also with the buy-in for our staff to feel that they're really customizing this by their team, by the communities they're serving. Each team is able to choose their own measures with some guidance from myself and from OWL and their measures manager. We do try to have consistency across the board, especially as it relates to CCBHC requirements. We are tracking depression and suicide risk across the board, but there's very few teams that use the exact same measure bundle. Just again, because each team is a little bit different and serving a little bit different of a community. They automate the bundle so people get them automatically, but also with OWL, you can also customize based on your client. So we trained all of our teams. Every team had 1 to 3 trainings on OWL. That includes just sort of your everyday use of it, but also how do I customize this on a client by client basis? So my client may be getting these specific measures every 2 weeks, but I also really want to look at looking more closely at their trauma and really targeting these specific symptoms of that. So I'm going to add this additional trauma measure. So we are training and taught everyone kind of how to maximize their use of the tool. We also partnered with our learning and development team to create an internal training for our new staff. So the implementation and rollout took a considerable amount of time across our center across those 25 teams. And so once we were done with that, we know it doesn't end there, and we're going to have new staff coming in all the time, and they're going to have to learn OWL as well. So we created an internal training to help new clinicians and client-facing staff. So there's a couple different versions based on your role that people take within the first month of their onboarding to get that initial training, and then they work with their individual manager for the kind of unique aspects of their team. We also have built in processes with HR and IT for onboarding and offboarding as well, just to make sure we get people in the system enrolled in all our clinicians and then deactivating them on the way out. So we finished all the implementation work late summer of last year, 2022. Right now, our focus has really been on compliance, really continuing to work to champion, have our leaders champion this on their teams, and continual training, and then also analyzing and understanding our outcome status. So that's where we're going to move to next.
Great, thanks Amber, Kirsten, and Kathy for presenting all of that. And I hope that gives everybody an understanding of how this looks like when you actually move from the general idea of measurement-based care to actually implementing it in a day-to-day perspective. I want to walk through some of the outcomes that Aurora Mental Health and Recovery have seen in terms of the OWL and the data that they've been able to pull from it. Let's start first with one of the things that's most important, which is engagement. You can have a really great measurement-based care tool, but if nobody is using it, it's useless. You can have all the measures in the world, and if your patients are not filling them out, you're not going to get that benefit. So what we do see here is a replication of what we're seeing broadly within OWL at Aurora, an 87% patient engagement rate. What you also see in this graph, though, is that some months were as high as 95%, and then there was some dipping in the summer. And Kathy, Kirsten, or Amber, I don't know if you want to jump in and kind of talk about where we were able to kind of locate where that change was in engagement.
Sure. So we have a large school-based team that works in a couple different districts and has a number of charter schools too. And the team is about 60 clinicians, and they work 11-month contracts. So they do not work over the summer, of course, because kids are home and not in the schools with our therapists. So we noticed a dip based on those clients not completing the measures, which I think also offers an opportunity this summer to do things different, because just because those students are not actively engaged in treatment over the summer doesn't mean we couldn't push to make sure they're still completing the measures, and then that we're tracking their progress over the summer.
And I like to spend some time on this because it identifies two important things from my perspective. Number one, the utility of aggregating data and looking at it, right? We can look to see, okay, what's going on? Why is this happening? And generate some hypotheses, go back to our teams, and not only as it relates to patient engagement, but anything that we collect and aggregate within the system. And it allows us to problem solve and also understand how might we do this differently. The other thing that I like about this is it highlights the importance of outcomes and measurement-based care with engaging patients or clients even outside of the therapy appointment or the medication appointment or whatever service that you're providing. So it can allow for check-ins, for example, and identify clients who maybe are in need of coming in when they don't have an appointment set for another 3-4 weeks, but it's important for us to see them. So I'm going to move to a slide that shows that in a more significant way. One of the things that we assess in many of our measures is suicidal thoughts and also any sort of suicidal behavior. The OWL will actually send an alert. That alert will show up both on the OWL dashboard. It'll also come in the form of an email that will allow the clinician to know that something is going on with their client as it relates to risk for harm. And so looking at, I think this was a 6-month period of time, we saw about 2003 alerts, which might seem like a lot, but given the number of patients that Aurora Mental Health and Recovery see is actually not, and fairly expected for what you would see with the severity of populations that they deal with. So that in and of itself, not terribly surprising. What was surprising to me is that 99% of those alerts were acknowledged, right? The Aurora Mental Health and Recovery team reacted. They saw that. They acknowledged those alerts directly in OWL. And even more shocking to me, right, is that we were able to then track to see, was there a schedule change to be seen as soon as possible? 90% of the time that occurred. And to me, this is measurement-based care. We are collecting data and we are responding to it as clinicians. We are reacting to it in a way that helps to improve the effectiveness of the services that we provide, and particularly in this case, to keep our patients safe, to make sure that we are giving them what they need when they are communicating to us that they are in crisis. So this is a really key finding for me. This is something I know when we first got these data out, I was just out of my skin, like excited about this. I don't know if the Aurora team wants to comment on this at all, but to me, this was really significant.
Amber?
I think one thing I can mention is that I think in a lot of these cases, not only was the appointment moved up, but potentially manifested that same day via the outreach the clinician made, and that turned into a service. So really intervening same day is probably what's happening in a lot of these cases. And then in others, maybe moving the session to tomorrow instead of in 2 weeks. So yeah, it's really, for us, very encouraging as leaders to see our clinicians responding very immediately to risk. And not everyone, it's really any sort of risk, even minimal, we get a notice for, an alert for. So there are times when we don't need to see somebody sooner. Maybe they always endorse a very low level of passive suicidality with no intention plan. But yeah, to see that 90% of the time we're intervening in some way sooner is really exciting for us.
Great, thanks, Amber. Another data point I want to show everybody is a little bit more detail on some of the data that I showed earlier. The general understanding within the literature is that measurement-based care is associated with better care. It's associated with more effective, more efficient care. And we're seeing this again at Aurora. So a 56% reduction in time to remission for patients that are consistent OWL users. And I think we call that 90% of the time that they are assigned measures, they complete measures. That's what we're identifying as a consistent OWL user. We're seeing that with those users, the average time to clinical cutoff is 6.4 weeks. So they're getting better faster when you can use the measurements to help to drive care. And again, this is we were looking specifically at clinically complex patients who had above a clinical cutoff on one or more measures. And so these are not, you're worried well. These are patients who are, or clients who are suffering and who are in need of help. And when we are providing them measurement-based care, we see that we can get them better faster. And we even see that with both moderately severe and severe patients, right? So we are seeing that time to clinically significant improvement within 6 weeks. Even with patients that are really at the severe level at the time they come in, 30% of them are showing clinically significant improvement. And we do even better with those that are coming in not as severe as one would expect. And so what we're seeing is that even when we kind of divide up the patient population according to their level of severity, we're seeing that effect regardless. And that to me is showing the robustness of the impact of measurement-based care on our patients. It's really helping them to get better faster. I also hinted at this earlier, is how can we use the OWL to identify opportunities to take the greatest advantage of all of our resources and to use them in the most effective and efficient way possible. We all know that this occurs within the mental health field, that there are patients that we're seeing over time that have really been doing well. And sometimes when they're doing well, we continue to see them. And so we have a front door problem in mental health. We struggle to have wait lists that are not a year long. I know even in my own clinic, I actually stopped taking referrals this year because I got to the point where I was booking so far ahead that it didn't make sense. So we have to figure out how to be more efficient to really provide the care that we need to give to the clients who are at the highest risk. And one of the ways to do that is to use measurement-based care to help us to identify who are the patients or the clients who are potential candidates for, we're referring to it as a step-down care. I think there's many things that you can refer this as, but how do we move patients or clients to less intense resources? So if we have somebody seeing a psychiatrist in a frequent basis, but yet they're quite stable. I was just talking about this with my leadership team at Northwestern Medicine. How do we move them perhaps to an advanced practice nurse? How do we move them to a PA? How do we move them to their primary care physicians? Because they're stable. They don't need to be seeing that high level of expertise within psychiatry. If somebody is going weekly therapy and is showing a significant improvement and sustained improvement for periods of time, Do we need to see them weekly? Can we move to every other week? Can we move to monthly? Can we move into a check-in process where we, just like when we get our teeth cleaning, coming back every 6 months to see how are we doing, anything that we need to work on. Things are great, see in another 6 months. How do we work to take advantage of the greatest resources, or take advantage of the resources we have in the greatest way possible? And again, with Aurora, we're seeing that 30% potential for increasing capacity, even with existing resources, by working on that backdoor problem. How do we get patients out? And therefore, we increase that front door opportunity. So anything on here, Kirsten, Kathy, or Amber, that you'd like to add?
I think for me, just the fact that right now, I think our focus is more on client by client. How is this data looking, and what kind of decisions can the clinician then make based on the data? Our next steps are to really use this data more at a team level, at a division level, at a center level, to help us with our planning for what do our clinics need to look like? Are additional resources needed, or do we have resources that we can better utilize, as you're mentioning? So I think those are next steps for us.
Yeah, I'm glad you mentioned that too. What we don't want to use this as is, oh, you've reached 4 months of stability, you're out, right? That is not what we want to do. What we wanted to do is to inform a question gathering. Is it necessary for this patient to still receive the services that they're receiving right now? And the answer might be yes. The answer might be, oh, yes, they're doing great on these measures, but we're actually not measuring the thing that they're really struggling with. Then let's go ahead and measure that. One thing that we have found is, in some preliminary data, is that if we measure more specifically to the problem that the client has, we can also maximize the effectiveness of our treatment and the efficiency of our treatment. That when we measure specifically, we actually see even a greater response to treatment than if we're just measuring something more broadly. So that level of specificity, even if it answers that question for us, will ultimately result in our patients doing better. But it's really the start of a conversation, and that's what these data will help us to do, is to figure out how do we make and take the greatest advantages of what we have available to us to help the patients or the clients in greatest need. All right, and with that, we are coming to the end of our presentation, and we want to thank you all for attending. The good news here is that we have plenty of time. We actually have a good amount of time for questions and discussions, and I'm actually going to stop the screen share here and turn it over to Corey to see if there's anything that's popped up in the chat.
Absolutely. Thanks, guys. That was very informative. And got a couple questions here we want to get started with. And actually, I'm gonna pitch the first one at Kathy. Right now the C-suite is, maybe they're looking at this and they're saying this is a great idea. A couple questions. First is, how long from time to start the pilot to full implementation? Second would be, like, how do you fund this? And how do they use that to improve their market positioning? Because I think that's going to be a big question for our listeners.
Yeah, thank you. So several questions embedded there. I think time from start to full implementation for us was about 18 months. The integration took a full year from start to finish. And that was the piece that was, I think, the lengthiest. So that's the factor that could vary depending on what EHR you're using, and has OWL been integrated with that EHR in the past? What kind of resources do you have? That kind of thing. I think the other piece that added the rest of the time is the team by team approach that Amber mentioned, which we think is what has led to really positive adoption. I think that if we had tried to do this at a higher level without that really individual attention and specific discussion at each team, we don't believe we would have gotten the adoption that we wanted. So I would say that's to full implementation of actual use. We have a lot of continued opportunity for how we analyze data and what kinds of workflow changes we may make or other programmatic changes even that may come from that data analysis. So we definitely see that as a work in progress. Remind me of the other two questions, please.
Absolutely. You know, what are some options for funding something like this? How would you fund it? And you know, how do you use the tool to improve your market positioning in a competitive kind of way?
Gotcha. So opportunities for funding, as I mentioned earlier, we were fortunate in that we had SAMHSA CCBHC expansion grant to get us started. And so we did utilize that funding. You know, that is often a model in organizations like ours where we seek external funding to support the start for systems like this. And so that was what got us out of the gate. I think we see the value in OWL on an ongoing basis. So it is part of our operating budget from here on out. And that being said, we are starting to have a lot more discussions with folks in our state sort of government structure. One of those very specifically is with our Medicaid authority and the local organization, the local managed care organization for Medicaid in our region. And they're very, very interested in the outcomes that we're seeing, in the technology that we're using, and they're thinking about how could they support this kind of technology in the provider community? Because ultimately it adds value. It increases access, as we were discussing. And so there may be some larger funding options that start to open up for us. And I could see similar things happening other places. I think as far as improving our market position, for us, it's really about how we interact not only with our community and our potential clients, but with the broader behavioral health community in Colorado, the relationships that we have with our Medicaid authority, with our state behavioral health administration, those are all really central to our work. And I think that our use of OWL and our ability to be able to talk about the outcomes of our clients in a much richer way has really gone a long way toward improving those relationships, probably improving our reputation with those organizations as an organization that is really willing to innovate and to take the time in order to make a system that really optimizes clinical care work. And so the word starts to get out in that way, I think. And that's been very positive for us so far. And ultimately, as Jason was saying, for us, it's about access as well. Access is super important, and we want to be able to provide the best possible access to our community. And so the more efficient we are with our treatment, then the more our front door opens. And so that's another piece, I think, that is really a market differentiator for us.
Thank you very much, Kathy. I apologize. I gave you a big one. That was a really great answer, as long as it was. Well, we're going to back up. You mentioned the work that Amber was doing. And so, you know, Amber, can you jump in a little more deeply on the clinician buy-in process? I mean, how did you convince them that this was a good idea?
I think it's an ongoing process. You know, that as Kirsten mentioned, sometimes it can feel like one more thing. There's a lot of changes happening. There can be change fatigue. So I think the customization helps a lot because people then feel like you're really hearing what our needs are on this specific team, the challenges we're going to have with this, how can we strategize, create processes to simplify this as much as possible. So I think that has been a big part of the initial buy-in and just that really spending time with people, really learning more about the program, how to make this work. I think training around measurement-based care, some of what Jason talks about today, you know, in terms of why does this matter? Why is this important? We actually had a training today, this morning, with our clinical leaders on the clinical utility? What are some of the best practices? What are the things you're using on your team? How do you talk about this with your client? How do you use this as an intervention? I heard talk about, this is a great way for our SMART goals in our care plan is measure by OWL. So really working with each other, doing a continual training, helping people really understand the benefits of measurement-based care broadly, and then really bringing it down to on a, one-on-one clinician level, this is the best way you can use it with this client. So I think it's an ongoing process for us. I think the more we get data and outcomes, that's exciting for our staff to see. I think sometimes we feel like clients are stuck or we're not seeing a lot of progress, and especially with some of our higher intensity and acuity teams. And so I think sometimes the data is surprising in a positive way of, oh, wow, okay, yes, we talked about that today, that this can help increase self-efficacy for clinicians, to help them see like, wow, I am seeing progress and change. So I think the more we see the data, that is another way to continue to increase buy-in.
And just to build on that, Corey, real quick, we also see that buy-in and that kind of self-efficacy as also a way for programs to retain their clinicians. Because if they can feel good about what they're doing and they can see it in black and white on a piece of paper, that'll help them to feel like they can do this. They can keep doing this hard work. And this day and age when it's hard to stay hold of our clinicians, I think that's also an important factor.
Yeah, I would say some of this sounds like ongoing obstacles a little bit. Kathy also talked about some of the obstacles of forming this relationship. Kirsten, could you add from your perspective what some of the biggest obstacles or the biggest obstacle that should be taken into account in an adoption like this?
I think there's a number of things to work through to make something this large launch successfully. And one of the bigger obstacles is the way that we chose to implement this was an extremely time-intensive way to launch this. And Amber does have a full-time job that she is responsible for that does not include launching the OWL implementation. And I think her approach and technique in terms of how she did implement this across the center really led to its success. So as much as that was an obstacle to overcome, I don't think we'd be where we were if Amber didn't invest the time in making sure that people were bought in and they really understood how to use the tool. And she provides technical assistance to people to make sure that the technology isn't a barrier to them or scary to them. So that was really a big key, I think, in us overcoming and navigating to be sure that we had our entire clinical team bought into what we were trying to do here.
All right, thank you very much. I'm looking down through some of our questions here. Well, I guess we'll just throw it out there. Vendor relationships are extremely important, right? So obviously you guys have a great one with OWL. Can you share some of your experiences, maybe a little depersonalized so we're not putting Jason on the spot, but anybody from a tech perspective that are going to go out and try to find somebody to work with. And what would be your advice to make that a smooth process where you get what you need and you find somebody great to work with?
Yeah, that's a great question. I think that as many organizations, we have had positive experiences with vendors and not so positive experience with vendors, and certainly understand that what we hear in a pitch for maybe a new product or something like this is not always what we get. And really for us it was, can we see this? How can we see it working? How do we know that that what we're hearing is what's actually going to be possible for us? And I think that we were able to establish a relationship early on that allowed us to kind of take the time we needed, that allowed us to see the product working, that really got our questions answered. And still, I think that the biggest surprise for us with our OWL implementation was the time it took to do the integration. I don't think we were expecting it to be as lengthy as it was. And ultimately, it's what also helped make this a successful implementation. So I think there's always surprises. I guess, you know, one recommendation is just to expect that, right? And I think that for us, this has been a very positive experience, as you mentioned, a very collaborative experience. I think the data sharing back and forth has been so valuable. So ultimately, I think that this particular relationship and this particular product has really performed better than most in my experience.
I think another key to that is it's impossible, as we're being pitched a product, it's impossible for us to really present the complexity of our system to anybody else as well, because we are a complex system. And I think OWL really demonstrated throughout this process a desire and a willingness to be flexible and adapt to all the different needs of our different populations and the needs of our EHR. And we still get questions, can OWL do this? Can OWL do that? And Amber is able to work closely with the folks from OWL to try to adapt and flex what they have so that we can meet the needs of all sorts of different specialty populations and specialty programs that we have. And that's been really important too. The other thing I would say is having the right people on both teams has been important. So Amber is not trying to represent us technology-wise to OWL. We have an internal team that she works with so that our IT folks can talk to the IT folks at OWL. And we have our subject matter expert clinically, Amber, talking to the subject matter experts clinically at OWL. So that's been really helpful too, I think, to have teams internally that can talk to each other in the language that we all speak in our different fields.
So, one of the slides said there were 300 plus clinically validated measures. You know, what's the process that you guys went through? And I'm not sure who to ask directly to choose which outcomes are most important. You know, how do you guys vet of the 300 plus in this platform or the 1,000 you guys would love to have? Which ones do you narrow down and say, this is how we've chosen these outcomes?
I can take a stab at that. I think, you know, one of the first things that matters a lot to people is how big the bundle, so again, a grouping of measures is, so how many items. We really want to avoid fatigue for our clients. And so that anything that had a lot of questions in it generally is avoided for us because most of our clinical leaders will be like, ugh, this is probably not going to go well for doing this on a regular basis with clients. So that's one of the things we were kind of looking for across the board. I would add up how many questions per bundle for folks, but really it was those meetings with their clinical leaders. So talking to the directors more about, hey, what do you want to see for your teams within your divisions? And then also the managers within the team of what are the common symptoms, presentations you're seeing on your team, what would be helpful to track. You know, because this is automated. So essentially the way it works is that anyone coming to you all getting these services is going to get this bundle. So we want to make it so that it applies to the majority of the people coming to your team. And for some teams, substance use outpatient team, they're going to really do some measures specific to substance use, while other teams may not be doing that. So it was really kind of vetting that across our leaders. And then I also consulted quite a bit with OWL has a measures manager. She's a licensed psychologist. Sometimes we would say, we're really looking for this unique sort of thing. Instead of me going through the entire library, I bet you could more quickly identify. So she would often put together kind of little packages, like here's what I think for this to target that, which was really, really helpful. So we also consulted OWL, their manager as well, who has that subject matter expertise.
All right, thank you. Well, we have a couple minutes left. And if you each take about 30 seconds to give a final advice to our listeners and what they should keep in mind, and anything else you'd like to throw in, we'll start with Dr. Washburn.
Well, first off, I just want to thank everybody for being here today and thank the panelists and Corey for for having us here. I think the biggest thing that I will say is measurement-based care works. It's important. However you end up doing it, let's do it.
All right, Kirsten.
I think that the data speaks a lot about how much this impacts folks. And I think, as Amber said, we had a large meeting this morning in training with our clinical leaders, and hearing some of their personal stories about the impact this has made on our clients and the progress that they have seen by using this really kind of hits home to me even more than some of the numerical data. So it really has made a powerful impact on our communities. Thank you.
All right, Amber.
Thank you also. And I would say that one of the things that I've been thinking a lot about is seeing the data and how it really affects our clients, that we are seeing clients get better sooner and how powerful that is, and that we should really be doing everything in our power to make that happen. So that's part of my thinking, and some of that buy-in for people is that let's get our clients better sooner. Why aren't we doing this? We should be doing this. So I'm with Jason. I'm on that train as well.
All right, that's great. And finally, Kathy.
Yeah, I think the client experience is key. I think that's the most important thing that you've heard today. And I would also just add, we talk a lot about value-based care and value-based contracting, and we don't always have a clear and easy way to do that. And I would say that using measurement-based care and the outcomes that come along with them is a package that can really reinforce the concepts and move you forward in the value-based care arena.
All right, thank you very much. You guys have been great. I want everybody to know who sent a question in that we didn't get to. We have your name, your email, and your question. We will be in touch with some answers. And I want to thank everybody for joining us today. I want to thank our speakers for joining us today, and to remind you that the slides and recording for this will be available tomorrow on the Open Minds website. The full Circle Elite Executive Roundtable series is also available on demand as part of the Extension Open Minds library, which is on YouTube. And for a full list of upcoming roundtables, you can visit our website at www.openminds.com. Thank you very much, guys, and I hope you have a wonderful afternoon.